So, good morning everyone. Today we will continue with the signs of the brain, part 7. I think maybe the last part or the part before the last part. Anyway, so let's see what's going on here. What's this? Mickey Mouse ears sign. Excellent. So what does this indicate? Hydrocephalus, exactly. So this is a coronal CT scan showing ballooning of the lateral and third ventricles. As you can see, just a second, lateral and third ventricle, just looking like the ears of Mickey Mouse. This indicates internal hydrocephalus or hydrocephalus, which refers to increased CSF accumulation in the brain, either internal or external. The internal is within the ventricle. The external is within the subarachnoid space. Okay, the Mickey Mouse ears is referring to internal hydrocephalus. Okay, external hydrocephalus refers to enlarged subarachnoid spaces with normal-sized ventricles, which is a benign condition of infancy, resolved spontaneously by 2 years of age. The external hydrocephalus, while the internal hydrocephalus is produced by obstructive, which is the non-communicating, or non-obstructive, which is the communicating causes. It's either obstructive or non-obstructive, okay? In non-communicating hydrocephalus, there is a blockage of the flow within the ventricular system with continued upstream CSF production causing progressive dilatation. So the CSF is produced up in the ventricles, but it cannot go down due to some sort of obstruction, usually at the Sylvian aqueduct, usually, but not always, okay? In communicating hydrocephalus, the ventricular system is patent. Everything is okay, but the CSF overproduction or impaired absorption by the arachnoid granulation resulting in increased CSF volume. There is characteristic ballooning of the lateral ventricles, creating Mickey Mouse ears appearance. Ventricular drainage or shunt placement can serve as a temporizing measure, but definitive treatment requires identification and correction of the underlying cause. So what they put CSF shunt to decrease the CSF volume and pressure. Okay. The true hydrocephalus should be distinguished from cerebral atrophy, which results in vasodilation of the cerebral ventricles. When the brain atrophies, the ventricles dilate due to loss of volume of the brain, not due to CSF overproduction or CSF increased pressure. Okay, the brain atrophies. CSF will get more, okay? Called vasodilation. Good? Okay. هاي المفروض next one المفروض آلاء تعرفها إذا أنا ما متوهم. فوجي ماونتن، مو قدمتيها مرة من المرات؟ لو منو قدم فوجي ماونتن؟ منو؟ آريان. كانياو؟ Yeah. زين حافظت الفوجي ماونتن. Good. So this is a Fuji mountain sign. Or Mount Fuji sign, whatever. Indicating what? Pneumocephalus. Good. Either post-surgical pneumocephalus or tension pneumocephalus, which is a normal finding after surgery or trauma with violation of the dural space. Progressive air accumulation can develop due to the ball valve mechanism, just like the lung, pneumothorax, pneumocephalus, the same idea. Okay? Can be tension or can be just pneumocephalus. Producing mass effect on the adjacent brain if there is tension pneumocephalus, which is an important sign. Also, an important sign of the tension pneumocephalus is compression and separation of the frontal lobes, resembling the double-beaked silhouette of the Mount Fuji in Japan. The presence of gas within the interhemispheric space indicates that the air pressure exceeds the surface tension of the CSF between the frontal lobes. Tension pneumocephalus is a neurosurgical emergency requiring immediate decompression. Yani when you see this just here air, this indicates pneumocephalus. Can be due to the trauma, can be due to post-surgical changes. When the air gets in between the frontal lobes in here, this is the sign for the tension pneumocephalus. This is the surgical emergency. You should not see it between the frontal lobes. You see it over the frontal. You should not see air at all, but if there is You need to distinguish whether this is an emergency or not.
Patient cannot tolerate this condition because severe headache will be
Well, if it is post-traumatic, he's unconscious, how are you gonna know? It can be just pneumocephalus due to fracture.
severe headache.
اوكي اذا هو unconscious شلون تعرفين هدف؟
آه.
Post traumatic جاي ب RTA, road traffic accident, he's unconscious, he's bleeding, he's whatever. You don't know. You can't examine her. You should look for this particular sign.
Excuse me, sir. Last time we saw a case, it was a CT for a dead person.
Okay.
We saw this finding. Really, we didn't know what to write. How?
Indicating tension hydrocephalus. What's the emergency بالtension hydrocephalus? يعني ليش it is an why it's an emergency? It is predisposed to brain stem herniation. So tension hydrocephalus can be fatal. Okay, maybe according to the condition, according to the history. Okay, يعني هاي emergency بالموضوع. Okay, so what do we have here? Any idea? What's the diagnosis? Differential. Sorry? Good job. What else? With hemangiopericytoma, other possible differential diagnoses? Atypical meningioma. Okay? And, of course, don't forget metastasis. Okay? So, what's the sign? It's called the mushroom sign or the PANNUS sign. Okay? Just like something like that. This is a sagittal contrast enhanced T1 weighted MR showing mixed solid and cystic mass with scalloping of the inner table. You can see the inner table of the skull is scalloped just like that, with a transdural invasion and invagination of the frontal lobe. It's going both ways, into the brain and into the overlying bone. Okay? حتى can be very difficult to differentiate whether this is extra or intraaxial lesion. It's going both ways. Okay? So, can be either hemangiopericytoma, atypical meningioma, and metastasis, the differential diagnosis. Hemangiopericytoma previously was known as angioplastic meningioma. هي نفس الهيمانجيوباريسايتوما. Angioplastic meningioma, إذا تقرن بالhistopathology, sometimes they report that, is the same as hemangiopericytoma. It's an extraaxial lesion with a classic imaging appearance, with mixed solid and cystic mass, avid post-contrast enhancement, flow voids reflecting hypervascularity, neurodural attachment, and erosion of the overlying calvarium. You can see the neurodural attachment here, the marked post-contrast enhancement, the invasion of the brain, of the bone, with creating the mushroom appearance. This is the mushroom appearance, is the neurodural attachment and brain invasion, like a mushroom. Okay? In contrast, the meningiomas are more homogeneous, often calcify, have a broad dural base, and produce bony hyperostosis rather than erosion. The meningioma causes hyperostosis, while atypical meningioma or hemangiopericytoma produces erosion. You have to differentiate between the two. With the extradural variant involving the calvarium and subcutaneous tissues, intraaxial invasion is rare, suggests malignant transformation. The broad dural attachment is usually produces what's called PANNUS rather than mushroom appearance. Metastasis may have aggressive behavior with dural, calvarial, and or parenchymal invasion. So this appearance can be due to extraaxial lesion invading the brain or intraaxial lesion. You cannot be so sure. Okay? نجي على your weak spot. What's this? What's the modality? بس قولوا لي الموداليتي شنو هي؟ nuclear شنو يعني nuclear؟ SPECT. What يعني هذا الكونتراست وين مطي؟ IV, IM, intrathecal, exactly. So when we imaging this, it's called cisternogram. DTPA cisternogram. Okay? Showing. Can anyone knows the sign? ما أعتقد صعب يعني. This is what's called the trident or the triumvirate sign or appearance. Trident appearance. Like you can see the trident هذا سهم ثلاثي trident just like that. Okay, so this indicates what disease? The trident appearance. إذا تذكرون, if you remember previously we saw what's called the heart sign. It was when the contrast accumulates in the ventricle and leave the CSF space. إذا تذكرون previously. While now it's exactly the opposite. The contrast is not in the ventricle, it's just in the CSF space. This is the spinal cord, or the fecal sac, let's say, not the spinal cord. This is the normal appearance. This is what should normally happen. This is a normal pattern, the trident pattern, okay? Sorry, just like here, you can see, this is the trident, just like here, trident. A cysternogram with DTPA indium labeled, showing the expected ascent of the pharmaceutical from the intrathecal injection site. We'll do an LP puncture, inject the radioisotope, and we wait for it to ascend up, covering the cerebral convexities with no ventricular reflux. The CSF produced in the ventricle gets out. So it should not the radioisotope should not be in the ventricle, should be in the subarachnoid space, okay, over the cerebral convexities. After we inject the DTPA, indium 111 labeled indium radioisotope, we start imaging the brain to see the ascent of the radioisotope, sorry, not the contrast, to the level of the basal cistern. Usually by 1 hour we see the basal cistern. The timing here is important. 1 hour you should see the basal cistern. Okay? What's going on? The frontal poles and the sylvian fissure should be seen by 2 to 6 hours. The cerebral convexities should be seen by 12 hours, and the sagittal sinus by 24 hours. So here you expect this appearance to be seen at what timing after the radioisotope injection? 2 to 6 hours. The cerebral convexities should be seen after around 2 to 6 hours. Okay? Normal activity in the interhemispheric and sylvian fissure creates the standard trident appearance. The tracer does not normally enter the ventricular system because the physiologic flow of the CSF is in the opposite direction. The CSF flows from the ventricle into the subarachnoid space for absorption. Okay? Good. What do we have here? It's a brain MRI, T2, axial, showing it's a little bit difficult one. This is what called nibbled cortex. Nibbled يعني معضوضة. Cortex bitten. I don't know how to. Okay, this is what's called nibbled cortex. Just like this donut has someone nibbled it. ماخذ عضة منها. Okay, this what's called Needon syndrome. The S is silent, or Sneddon syndrome, whatever you like to call it, There are multifocal encephalomalacia with cortical irregularity and subcortical hyperintensities. Okay, this syndrome is a non-inflammatory arteriopathy. It's a vascular problem. The arteries are abnormal. Most cases are idiopathic. Some are familial with autosomal dominant inheritance. Antiphospholipid antibodies are positive in 50% of cases. Okay, so it's some sort of vasculitis. Patients suffer from vasospastic episodes, transient ischemic attacks, stroke, and early onset dementia. Small and medium-sized vessels are affected with asymmetric, multifocal, cortical, subcortical infarcts. Okay, you can see nibbled, cortical and subcortical infarcts, multifocal, bilateral, asymmetrical areas of cerebromalacia. In nuclear medicine, SPECT, CT perfusion, MR perfusion studies may facilitate the early diagnosis, identifying the underperfused area prior to the development of irreversible infarct. In the late stage disease, there is multifocal encephalomalacia with subcortical white matter signal abnormality and irregular volume loss of the overlying cortex, what's called the nibbled cortex. So this nibbled cortex appearance is due to multifocal cephalomalacia in a relatively young age group, due to arteriopathy, autoimmune disease, antiphospholipid antibodies are present. This indicates late stage. When you see multifocal with brain atrophy, معناها البيشنت late in the diagnosis. Okay? Okay. So, what's this? Diagnosis. Anyone can give an idea about differential or diagnosis? Sorry? CP angle mass. Do you think this is the CP angle? First of all, benign or malignant? Intra or extraaxial? Extraaxial? Do you think this is an extraaxial? It's an intraaxial, right? Then, benign or malignant? شنو الموداليتي? What's the modality? MRI T1 post contrast. So, benign or malignant? What do you think this hypointense around the lesion is? It's an edema, vasogenic edema. Okay? Surrounding a mass, intraaxial in the brain, benign or malignant? More in favor of an aggressive tumor. Right? Aggressive lesion, let's say a tumor. So, this is what's called a notch appearance. You can see the post-contrast enhancement. You can see the notch, like here. This is a notch in post-contrast enhancement, indicating or more in favor of CNS lymphoma. When you see this notch appearance, it directs you more in the direction of CNS lymphoma. Okay, shows left. This is the T1, shows the left temporal enhancing mass, multiple peripheral indentations. CNS lymphoma usually occurs in where? Immunocompromised patients. تمام? And immunocompetent after the 5th decade. يعني relatively old, نقول 5th decade is not that old. Okay? The enhancement pattern is homogeneous, solid in immunocompetent patients, but more heterogeneous and ring enhancing in immunocompromised. So if the enhancement pattern is heterogeneous, this indicates immunocompromised. You should look for some sort of HIV, possible AIDS infection, or other causes of immunocompromised patients. Okay? While if it is homogeneous, nice, looks all over enhancement, this more in favor of immunocompetent patient. Okay? Lesions can be multifocal and involve the brain parenchyma, vessels, ependyma, meninges. The notch sign has recently been described, refers to an abnormally deep depression on the lesion margin. There is a rare but highly specific finding that effectively distinguish primary CNS lymphoma from other primary and metastatic brain tumors. So it is highly specific finding to find these depressions in the diagnosis of CNS lymphoma. Keep that in mind, okay? So, what do you think is going on here? Sorry? Look like eyes. Eyes of what? Good job. They are eyes of what? Sword. Snake. Snake eye, cobra eye, owl also. Okay. So, what does it indicate? You معودين. صوت شنو؟ Demyelination. Due to what? Sorry? Toxic what? Basal ganglia, not brainstem. What else? Come on, girls. They are osmotic demyelination syndrome. Okay? These are the owl or snake eyes appearance in an axial T2MR imaging with hyper-intense signal within the central pons sparing the corticospinal tract. These are the arrows are the corticospinal tract. And the peripheral pons more in favor of osmotic or demyelination syndrome, which is previously they were called central pontine myelinolysis. It's the same as the osmotic demyelination syndrome. sometimes called extrapontine myelinolysis. It's caused due to what? Rapid change in serum osmolarity, which is in presently classically where? Alcoholic, hyponatremic patient undergoes rapid correction of serum sodium concentration. They give him hyperosmolar sodium chloride, okay? Leading to massive fluid efflux from the brain into the serum, resulting in symmetric T2 hyperintense signal and reduced diffusion and diffusion restriction in the central pons, the basal ganglia, cerebral white matter. Mild injury gives signal abnormality in the median, raphe, and basis pontis. In the pons, due to mild injury, okay? With a bilobed or what's called bat wing or triangular morphology. Bat wing morphology due to mild injury, okay? More profound injury, when the injury is more severe, they will affect the entire pons, sparing of the tegmentum, corticobulbar and corticospinal tracts, what's called the owl or snake eye appearance. So this indicates more severe injury. It's not mild. The mild is in the bat wing appearance, okay? In the subacute period, the signal change improve or resolve completely. The differential diagnosis includes infarction, neoplasm, demyelination, infection, metabolic disorder, and radiation. Okay, it's a differential diagnosis. However, the history of alcoholic with hyponatremia, rapid correction, this appearance very suggestive of myelinolysis, central pontine myelinolysis. Okay? So, what do we have here? It's just a very routine appearance. We see it every day. Don't overthink it. Every day in the MRI you see this appearance. And in the periventricular hyperintensity or hypodensity in the CT scan, if it's CT scan, indicating يلا differential diagnosis. Small vessel disease, which is the vasculopathy. Normal aging process can give you this appearance. What else? Torch. This is an elderly, usually see it in elderly age, older age group. Again, older age group. MS, demyelinating disease, excellent, and dementia and hydrocephalus, and it's in the form of increased transepidermal flow. So, even this appearance has a differential diagnosis of normal aging, vasculopathy, demyelinating disease like MS, for example, dementia and hydrocephalus. Okay.
The demyelination is different, right? The perpendicular.
Yeah, of course, the appearance will be different. Even in the hydrocephalus, the increased transepidermal flow will be different. But as a differential diagnosis, you should keep that in mind. Okay? So, there are foci of hypodensity or MR hyperintensity in the white matter. They also, another name for it is called leukoariosis. It's the same appearance. Leukoariosis, this appearance, the small vessel disease or the vasculopathy or the normal aging process also can be called leukoariosis, and are common incidental findings at imaging, increasing proportionally with patient age. كل ما يكبر المريض كل ما هاي findings more. Cerebral atrophy, vascular risk factors will increase this appearance. At pathology, there are foci of dilated periventricular spaces, myelin loss, and or gliosis. Periventricular signal abnormality greater than expected for the patient age should raise the question of other pathologies such as vasculopathy, demyelinating disease, dementia, or hydrocephalus with transepidermal flow of CSF. Okay? I think we have time for maybe one or two more signs. Let's see. What do you think is going on here? This is a little bit difficult one. What's going on here? What's the differential diagnosis for this appearance? What's this lesion? Intra or extraaxial? Come on, boy, people, help me up here. Intra or extra? It looks like an extraaxial, صح? With homogeneous post-contrast enhancement indicating What's the most common extraaxial lesion with homogeneous post-contrast enhancement? It's a meningioma. This is the first thing. What about here? What's this? Sorry? Infarction? Or is this a mass? It's a cyst. بالtemporal fossa, بالmiddle cranial fossa. What do you think is going on? Arachnoid cyst. Common is common. Rare is rare. هذا شعارنا. Okay? So, in both what يعني joins them is the dilated sphenoid sinus. What's called pneumosinus dilatans. Okay? Dilated sphenoid paranasal sinus. There is the contrast enhanced T1 weighted MR shows enhancing planum sphenoidale mass with enlargement and hyperaeration of the sphenoid sinus. Okay, you can see this, all of this is the sphenoid sinus, dilated. Okay, and again, the CT in different patient, there is an arachnoid cyst with hyperaeration of the sphenoid sinus. It can be either due to meningioma here or arachnoid cyst here. You should keep in mind the pneumosinus dilatans is refers to an abnormal dilatation of one or more of the paranasal sinuses without bone destruction or hyperostosis or mucosal thickening. Dilated, air-filled paranasal sinus. That's it, nothing else. Okay? The most commonly affected is the frontal sinus, followed by the sphenoid and then ethmoid and then maxillary. Usually, we see it a lot in frontal sinus, very big, prominent one. It has been described in conjunction with meningioma, arachnoid cyst, meningocele, nerve sheath tumor, sinonasal polyposis, and Dyck-Davidoff-Mason syndrome, fibro-osseous dysplasia, hydrocephalus, and trauma. All of these can be associated with dilated air-filled paranasal sinuses. The diffuse involvement of the paranasal sinuses and mastoid air cells is known as pneumosinus dilatans multiplex. If all of them, including the mastoid air cells, this is the pneumosinus dilatans multiplex, okay? Associated with mental retardation and craniofacial malformation. Spontaneous pneumocephalus can occur after minimal trauma. Other types of sinus air cysts include hypersinus, sinus enlargement contained within normal boundaries, pneumocele, sinus enlargement with bone thinning and erosion, and pneumatocoel, subperiosteal air along the sinus wall. Could have features. Every one of them has its own association. Okay, for us, the appearance of meningioma or arachnoid cyst, I think, will be enough if you recognize this appearance. And the pneumosinus multiplex, keep in mind, can be associated with craniofacial abnormalities, mental retardation. Minimal trauma can result in pneumocephalus in patients with pneumosinus dilatans. Okay? Okay, I think we'll stop for today because it's almost 9 o'clock now.
From this image, how you know this is extraaxial,
The
the meningioma?
meningioma, how do you know it's extraaxial? Well, first of all, you can see the brain parenchyma drooping over the lesion. It is not invaded by the lesion. The enhancement is typical of meningioma, which also favors extraaxial lesion. And you can see it's taking the shape of the underlying bone rather than the shape of the overlying brain. So you need more imaging T2 and T1 to confirm that.
Can you return back to the case? You said lymphoma.
Lymphoma, which one is that? The notch appearance. So
This is not extraaxial.
No.
There's buckling side.
no, there is no buckling. This is the brain parenchyma going.
From the outer side.
The brain parenchyma is surrounding the lesion with a very narrow angle between the lesion and the calvarium or the bone. So this narrow region is suggestive of an intraaxial lesion. You cannot, the brain parenchyma going inside the tumor. You don't see that with extraaxial pattern. You see that with intraaxial pattern. Okay?
I suppose that these are backlit sign of the
No,
brain.
no, no. The brain parenchyma are surrounding the tumor. Okay? Engulfed, some sort of engulfed. Tomorrow we will continue with the brain, with the signs of the brain. Hopefully tomorrow will be the last thing. We will cover a lot of signs of the brain. Okay? Okay, hello, goodbye.